Assalamu alaikum. Welcome everyone on board. Uh, we will just continue our discussion on the anesthesia complications. So today I will just start with topic of aspiration. So uh, what are the risk factors for aspiration? Yes, Abdul
The
Rahman.
full stomach patient,
Full,
emergency
full
surgery, pregnant in labor, and
pregnant.
late emptying in diabetes, in
Gastro.
obesity.
Any reason with gastroparesis,
Yes,
like autonomic neuropathy,
neuro,
progesterone mediated in pregnant, okay, and CRF. So CLD also. Like in that case, what precautions you can do in the anesthetizing this patient?
sir, we can neutralize the acid. We
Acid
can reduce,
prophylaxis,
yes, we
PPI.
anticipate.
Acid prophylaxis is one thing. Number two,
We can decrease the pH and acid production by H2 antagonist. We
so we neutralize
increase
the
prokinetics like
acid,
metoclopramide for
the acid,
increase.
increase the
Yes,
gastric emptying. Okay,
yes,
In-
metoclopramide
increase.
and
So
RSI.
what are other gastric prokinetic agents?
Uh,
Metoclopramide, domperidone,
Erythromycin, sir, is it
erythro
included in the term?
yes,
Erythromycin.
erythromycin. Okay, there is another medication which is called cisapride. Cisapride. Anyways, so these will be the prophylactic agents, and then you will do rapid sequence induction or modified rapid sequence induction. Another thing will be ramp position. Another thing will be you can measure the stomach volume by focus ultrasound.
Ji.
Okay, you can try to have avoidance of GA versus regional, but still aspiration risk will be there. So, but if a surgery can be done in regional, so it will be also a relatively safer option, but you will not over sedate in this case. Okay, you don't think that you don't have to consider at all about this thing. So regional will be one option. What else?
Sir, what is the scenario? The patient is having what sort of
Aspiration.
comorbids or
Aspiration. No. We are discussing anesthesia complications. So today we are just having few words about aspiration. So there is two terminologies. This is just a feeler question which they can ask. What is difference between
oh,
aspiration pneumonia and aspiration pneumonitis?
sir, aspiration pneumonitis is the chemical injury from acidic contents of the stomach. Uh, and the aspiration pneumonia, it could be the infectious process which could be oropharyngeal or others than acidic material,
Like
which
pneumonitis will lead to pneumonia. Okay. So no,
yes.
so it can. So another thing. So is there any role of antibiotics in aspiration? Any role of
Sir,
steroids in and any
role of
role of
steroid is
diuretics?
controversial. Steroids are
So
not indicated.
steroid role will be there if patient develops ARDS
And then
and
fibroproliferatic stage and that. So diuretics, no role. Okay. So
Yes.
no role of
So,
diuretics, no role of steroids, no role of antibiotic, only in
uh,
fecal
only if
fecal
infection is suspected.
fecal
Okay, sir.
aspiration. Okay, fecal aspiration. So
Sir, what
these
was
are
the difference between aspiration pneumonia and pneumonitis?
pneumonitis is the chemical reaction which occurs because of this acid, and pneumonia will be further leading to like development of bacterial infection.
Okay, sir.
So one of them is Mendelssohn syndrome. So Mendelssohn syndrome is not pneumonia, it's aspiration pneumonitis, if I'm not wrong. You see, Mendelssohn syndrome, peptic acid, aspiration pneumonia. So I was wrong. N- no, I think I'm correct. Anyways, you can reconfirm about it. I'm telling you the question because this is not a very big issue, and we can let's see. We have pneumonia versus aspiration pneumonitis. Actually, aspiration pneumonia are two different conditions that affect the lungs due to inhalation of foreign material. Pneumonia is a lung infection caused by bacteria in the mouth or stomach, okay, as he was mentioning. And pneumonitis is lung irritation caused by acid or toxic substance. So, uh, Safullah told the correct, Safullah or whosoever told, they are correct. Okay.
Okay.
Sir.
So, so pneumonia will be the further sequelae of aspiration. Okay. So, okay. So further we will dig into this topic. Just a second, please. What is the role of ramp position in aspiration?
Sir, with ramp position, the aspiration would not be occur because of gravity, or if it occurs, it would be in the oropharynx, so it could be suction easily. I hope so.
No, no, no. Don't use a like the word which you have used is very strong. Will not occur. No, it's not like that.
Oh,
That it
okay, sir.
says that the because when we are doing ramp position, the stomach contents need to go uphill so that more intragastric pressure is required. Okay. So the chances
Okay,
will be
sir.
reduced. But you are saying that it will not occur? No. So please, in the exam, never
Okay.
use this as a habit, as a protocol, never use these close-ended words because this can create problem. Then another thing is that there are two things. One is aspiration content, aspirant. The one is the volume, and one is the pressure. Okay. So if the pressure esophageal, when we are doing airway pressures, if they are going beyond 15 to 20, there are more chances of aspiration because it is causing aerophagia. It opens the lower esophageal sphincter. Similarly, if the content is more than 25 ml, there will be more chances. So that's the thing. And if it is fecal matter, the result will be worse. Okay. So we have discussed all these things. I'm just showing you the text. So this is, they can
So,
ask
sir,
you,
we can see,
yes,
sir,
yes,
sir, we can say that the pressure should be less than 15 to 20 millimeter
airway
mercury. I
pressure.
hope so.
Yes,
Airway
yes,
pressure, sorry, and the contents should be less than 25 ml, and
yes,
the
or
pH of the acidic
2.5,
or aspiration material should be
more
more
than,
than 2.5,
more
more
than
than
2.5.
2.5.
Very good, very good. Okay, so the management of aspiration is actually you will just ventilate. If it is significant, you will try to aspirate as much as possible. Bronchoscopy may be needed. And there is no
Yes, sir.
actually specific, if you there it's a infection, you will do the cultures and you will give associated antibiotics, and because there are chances of developing of VAP also. Okay, so See, usually there is no specific reason. Yes, most controversy surrounding treatment involve use of antibiotic and steroids. Even antibiotics, unless pneumonia develops, there is no need for. Yesterday we discussed about NAP5, that was for anaphylaxis, and this is NAP4 for aspiration. So you can have a look on NAP4, National Audit Project. So okay, so similarly associated topic is post-operative nausea, vomiting. So uh, like for that actually there is a scale. You see, risk factors are female gender, non-smoker. Okay, so if you are a smoker, it will give you a chances of having less chances of PUNV. So non-smoker, history of PUNV, and use of opiates. So if you have more risk factors, there are more chances of PUNV. And moreover, there are certain surgical factors. So there are certain
Yes,
surgeries in which more chances. So can you tell me which are the surgeries in which more chances of PUNV?
High and
ENT
middle ear
surgery,
surgery.
ENT
And
surgery, ear and the splint surgery, and of course there would, if the long duration of surgery, if laparoscopic surgery, nitrous oxide, if we use during
Long,
anesthesia, though.
surgical
I
surgery.
I don't agree with no long duration. Long duration is not associated with PONV, if I'm not wrong. Just correct me. I don't think so that long duration is a risk factor. Is it? Use of nitrous oxide is a risk factor. Okay.
Sir,
Inhalational agents is a
sir,
risk factor. If you are using propofol, it's an antiemetic. If
yes,
you any surgery in which the vestibulocochlear nerve, because that system is for the balance. So any surgery involving that thing, there will be more relatively more chances. So middle ear surgery is in another thing. Okay. So laparoscopic surgery, yes. Squint surgery and vestibulocochlear surgery. Okay, as I mentioned to you. So patient factors, previous history, anesthetic factor, nitrous oxide, inhalational agent, as I was telling you. Okay. So dehydration promote PUNV. So majority times we are not giving appropriate fluid. And the example is that when you wake up in the morning and if you have not taken anything, it creates a sort of vomiting sensation. Okay. Uh, First of all, Abdurrahman, if फजल साहब क्लास स्टार्ट करते हैं ना तो आप चले जाना बेशक. ठीक है.
Uh,
No
Sir,
problem.
I was thinking about attending the second half of the lecture.
What's the topic?
Sir, modes of ventilation है पहले तो बाद में फिर DCR डैमेज कंट्रोल रिससिटेशन.
नो आप उनकी पूरी क्लास अटेंड करो ताकि आपका वो हो. नो प्रॉब्लम. मैंने असल में लिंक भेज दिया था. आई एम सॉरी. मैंने इसलिए सोचा कि क्योंकि बहुत सारे लोग जमा हो जाते हैं तो आप जो जो एग्जाम कैंडिडेट है वो उनकी क्लास ज़्यादा कीमती है. आप उधर चले जाएं. ठीक है. नो प्रॉब्लम.
sir, I would thank you, sir.
यस.
ठीक हो.
तो
थैंक यू सर.
हाँ. तो sorry for this interruption. I was dictating them for some other thing very important. There is some other class going on, so I was just asking them to join there. So, anyways, so how you treat PONV? So, actually, better is the prevention. So, if you have any risk factors, you will try to use more than one medication. So, dexamethasone main role is not known, but dexamethasone is for prevention. Ondansetron, it's actually ondansetron and or granisetron. They are very powerful antiemetic, and they were formed for actually cancer-induced chemotherapy. Okay, so haloperidol is also antipsychotic. This is also having anti-emetic or anti like nausea property, and then powerful centrally acting H1 receptor antagonist. These antihistamines, the first generation. So they are being used. If nothing is working, actually, sometimes, like you will see in palliative care, propofol infusion is even being used for the terminal. management. There is another medication which we don't know much about it. I have not seen about it, but this is apripitant. So it is NK1 receptor antagonist. It can come in your MCQs. This is relatively newer medication. This is NK1 receptor antagonist. It is being used. It's I think licensed in US if I'm not wrong. Maybe I'm wrong because I have less information about it. Okay. So if they are asking you about PONV, what are the problems? If you have more PONV, electrolyte imbalance can occur. Discharge, it is one of the factor for delayed discharge from the hospital, whether it is day case or whether it is like any surgery. So it's part of enhanced recovery after surgery protocol that you should have minimum chances of PONV. Okay, so one some signals and input related to vomiting. So some cortical areas, limbic system. So ultimately, this nucleus tractus solitarius is involved, and then if spinal efferents and autonomic efferents to 2, 7, 2, 5, 7, 9, 10, and muscles alone will vomiting. So so that's how uh, this occurs. This aspiration. Uh, I'm sorry, vomiting. Okay. So these are all links are available. So you can have a look and okay. So we have discussed anaphylaxis, awareness, uh, ortho complications. Let's see. Tourniquet, I have discussed about it. Uh, I have few words about this rhabdomyolysis. What is rhabdomyolysis? Actually, it's you can say in any crush injury or anything which is causing muscle necrosis. So, when muscle breakdown occur, it can lead to toxic development of toxic metabolites, which can cause even renal failure. Okay, so some of the causes of rhabdomyolysis are crush injury, entrapment, and anesthesia related rhabdomyolysis can occur even in tourniquet. If you have kept tourniquet for a long time, it is one of the factor for rhabdomyolysis. Okay, so electrical injury, prolonged immobilization, excessive muscle activity, malignant hyperthermia causes rhabdomyolysis. We discuss in malignant hyperthermia and heat stroke, neuroleptic malignant syndrome, hypothermia rarely. I don't know with the ischemia. I think non-traumatic will be ischemic insult, substance abuse, alcohol, cocaine, amphetamine, ecstasy, drugs like statins. Statins they cause actually a muscle problem. So in very severe cases, it can cause it's not a clearly a cause of frank rhabdomyolysis. Okay, so some of the electrolytes like hypokalemia, uh, hypernatremia, these are relatively less common things. So clinical presentation varying. So CK will be high or even up to hypovolemic shock with life-threatening arrhythmias because it can cause renal failure as muscle pains and weakness are common. General malaise. Okay, dark colored urine may be the first indication of muscle damage. So classical triad of muscle pain, weakness, and dark urine, but it is seen in less than 10%. So the biochemical markers CK levels will be high. Okay. Mm, Okay. So, uh, uh, compartment syndrome. If there is any compartment syndrome, then even then, it can cause rhabdomyolysis. It can increase serum CK, rise in serum CK. Myoglobin is one of the significant compounds released after muscle disintegration. So, high circulating levels produce dark brown discoloration of urine. As myoglobin is filtered by the kidney, hematuria and myoglobin often coexist. Both things are occur, particularly in context with trauma. The absence of myoglobin does not exclude the diagnosis of rhabdomyolysis. So it's not mandatory. if you have a risk factor for rhabdomyolysis, you can think about it. Okay, so uh, so early complications is related to hyperkalemia because of cell lysis. So may lead to arrhythmias and cardiac arrest. So all things related to hyperkalemia, especially in association with profound hypovolemia, hypocalcemia, and acidosis. And like you can say late complication, early or late compartment syndrome may develop and exacerbated by the presence of hypotension. Compartment pressure greater than 30 millimeter are likely to cause significant muscle ischemia and subsequent secondary rhabdomyolysis. And late is DIC. Okay, so if DIC and renal failure, acute kidney injury is more serious complication. Okay, the mechanism not completely understood. Combination of renal vasoconstriction, hypovolemia, and mechanical obstruction, both of them will be not only because of vasoconstriction and renal blood flow decrease because of hypovolemia, and then further by this mechanical obstruction. So initially the same thing will be that airway, breathing, circulation. You have to think about it, and then things related to hyperkalemia. Okay, and if there is any surgical correction is needed, like fasciotomy or anything like that, it will be there, and rest of the treatment will be symptomatic. Okay, so baseline measuring electrolytes and ABGs, acute hyperkalemia will be treated, good amount of fluid therapy. Okay, alkaline your diuresis, there is no good evidence to show that alkaline diuresis is superior to sodium chloride. I think this is fluid management you have to do. And then bicarbonate, if the pH is less than 7.1. Alkalization of urine is achieved by using 1.26%. And bicarbonate, I have not used it ever, so this is just a factual thing. So, as I told you, that fasciotomy may be needed. Renal replacement therapy in case of AKI. So rhabdomyolysis, they can ask you with reference to crush injury, or you can mention about it. So immediate identification is very important, and then immediately fluid management, treatment of hyperkalemia, and compartment syndrome, as I mentioned, and AKI. If AKI occur, maybe CRRT or renal replacement therapy will be required. So we have discussed rest of the complications. Mhm. We have discussed many of the topics from here. Actually, yesterday we discussed about this uh, hemorrhage, hypoxia, local anesthesia toxicity. We have also discussed in our previous discussions. Myocardial infarction we discussed. Yes, so oxygen failure. Immediately, if oxygen failure occurs, ambo bag will be your actually solution, your rescue, and there should be emergency cylinder. That's why it's very important. Okay, open oxygen tank on back of anesthesia machine, which is and it's not empty. Disconnect pipeline oxygen to force flow from tank to circuit. Obtain full E cylinder of oxygen with regulator. Okay, connect gas sampling adapter to allow monitoring of respiratory gases. Mm, yes, another thing is that you don't have to give oxygen like anything. You have to reduce till the time this problem is resolved. Obtain extra backup sources of oxygen when patient more stable. Contact bioengineers to alert them to problem and enlist help with machine diagnosis. So inform our leadership that this is a actually topic they can certainly ask you. Pneumothorax. So pneumothorax, if it occurs, it's one of the differential of hypoxia as well. So if it is tension pneumothorax, there will be associated hemodynamic collapse as well. So simple pneumothorax, if you have done any procedure, any patient having bully, they will be at risk. High airway pressures, any conditions like in pediatric patients or in neonates, it can occur. Or so anyway, so there will be increased peak pressures, tachycardia, hypotension, hypoxemia, according to the level of pneumothorax, and then decrease asymmetric breaths, hyperresonance of the chest to percussion, okay, tracheal deviation to the other side, and increase JVP, high index of substitution to pneumothorax in trauma patients and COPD, okay. So this is the main thing. Or any patient in which the lung compliance is less, so we can do chest X-ray as a POCUS, or CT chest X-ray, or sorry, ultrasound as POCUS and chest X-ray, and do not treatment if hemodynamically unstable. So you can have this crash with the mid clavicular line, fifth intercostal space, second intercostal space for pediatrics, and we may hear a whoosh of air if under tension. I doubt this needle needle in deflation is in the second intercostal space. This is for I think mid axillary line, fifth to sixth for chest tube. Just reconfirm it. Anyone, mm, just reconfirm. Okay. What I remember is second intercostal space, mid clavicular line, not fifth. Maybe I'm wrong. I don't know. I have this confusion. If anyone knows about it, he or you just reconfirm about it. Because as far as I remember, it's second intercostal space. Power failure. Mm, yes. What is difference between total spinal and high spinal? Actually, total spinal, because cervical roots will be involved. So when cervical roots are involved, actually the patient will not be able to breathe for longer time. In high spinal, also there will be hemodynamic instability because of involvement of cardio acceleratory fibers, thoracic level T1 to T4. Okay, but still, if because of cerebral anoxia, this breathing problem can occur, or apnea can occur. But as soon as the blood pressure is maintained, cerebral hyperperfusion is decreased, the conscious level will be improved and apnea will be resolved. But if it is total spinal, because till the time this bupivacaine will not be metabolized, as this diaphragmatic tone is not coming back, patient will not be able to breathe. So this is something which you need to identify. So unexpected rapid rise in sensory blockade, numbness, or weakness in upper limb. This is actually suddenly even patient can have cardiac arrest even. Okay. Dyspnea, bradycardia, hypotension, loss of consciousness, apnea, or even cardiac arrest. So you will be air breathing circulation as we discussed, and then you will ventilate and hemodynamic support with inotrope vasopressors, and treat bradycardia with atropine or epinephrine, fluid bolus if it is parturient, and we have discussed about it. So actually today I will have a shorter session because majority of people are not here. So pardon me for that. We there was a confusion. We have our professor. He's taking a class. So I will stop here today. So pardon me for that. Tomorrow, inshallah, we will try to have like the remaining of the completion tomorrow. I will try to finish this topic of complications. So thank you all of you for coming. Bye bye.